Y'all, I just overbaked some fucking cookies. I put them in the microwave and they were hot as shit. So, anyways, ventilators. Ventilators are machines designed to move breathable air in and out of the lungs. They aid patients who are physically unable to breathe or breathing insufficiently. What the fuck? Breathing insufficiently to breathe. Okay, I need to fix that. Ventilators are equipped with a high and low pressure alarm. What the fuck does that mean? Okay, high pressure alarms go off ding 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 when they are triggered by increasing resistance to airflow. What should I look for? You're looking for obstructions. Sorry, I'm chewing. Obstructions. So think about, like, if I have a goddamn wind blower, like a leaf blower, and I put a rock up the leaf blower, and you can imagine, like in a cartoon, the leaf blower would just start to like expand because all of that pressure is building up, right? Of course, the leaf blower nor the ventilator expand. Instead, the ventilator is gonna throw off a high pressure alarm. What are some things that can obstruct and cause high pressure? Kinks in the tubing. What do? You fucking unkink the tubing. That's a really common answer. You have to look for kinks in the tubing. If there's no kink in the tubing, move on to condensed water. Most oxygen devices are supposed to be humidified, warmed a little bit. So, fun fact: the cilia of the respiratory tract, the upper respiratory tract, so like the mouth, not the mouth, the nose, work not only to filter out debris that you breathe in, but also to warm the air, because if it is too cold, it will shock the respiratory system. Sorry, I am eating and drinking because I could give two shits. Okay, so it warms the respiratory system, because otherwise, if it's too cold, it will cause some shock and pain to the body. Humans aren't really meant to. Oh my god, hold on. Alright. Humans aren't really meant to inhale cold air. So as a result or a consequence of that humidity, the little water droplets can, like, the condensation can build up in like the dependent parts of the tube. So that can eventually, if there's enough buildup, that it can cause some resistance. It's like an object blocking the airflow, and the machine will throw off a high pressure alarm. The third thing you're looking for is a mucus plug. You can ask your patient to turn, cough, and deep breathe. Now, if you see two answer choices that are appealing, they may be to turn, cough, and deep breathe the patient, and to suction the patient. Here's what you're going to do. This is important. The initial answer is to not suction the patient. Why? Because patients who can cough and clear the airway should be encouraged to do so. Because we go from least invasive to most invasive to preserve bodily autonomy, to encourage the patient to take care of themselves, and to encourage lung expansion and whatnot, all that shit, all that good shit. You're going to encourage it. So if it is obviously presented in the question that the patient can and is able to cough without, harming themselves, or the opposite is obviously fucking presented that the patient is sedated and unable to cough, use your clinical reasoning. If there's no regards to their safety, like if they're okay, the answer is to turn, cough, and deep breathe before suctioning. What are your order of actions? One, you're gonna unkink the goddamn tubing. Two, empty the water or that condensation out of the tubing. Three, ask the patient or turn the patient, ask to cough or deep breathe, and four, to suction. On the other side, what are our low pressure alarms? The low pressure alarms are always triggered by a decrease in resistance caused by. So I wouldn't know this because I was actually in continuing care and I was surrounded by ventilators 24/7, but I have no fucking clue how to operate them. So apparently there's a main tubing disconnection and an O2 sensor tube disconnection. Regardless, it's a type of disconnection. Because obviously if disconnected, the machine is gonna detect I'm not pushing against absolutely anything. So in both cases, you have to reconnect the disconnected tubing, unless the tube is on the floor, in which you use a bag valve mask and call a respiratory therapist, which is not my goddamn problem. Thank God, because I don't know how to use that machine. So, oftentimes when a problem, this is how they presented it to us in school by Miss Berkey. If there is a problem you cannot easily fix, so if you do not see, if you cannot imagine your dumb ass going in there and unkinking a tube or simply plugging something back in, then get your bag valve mask, and you know damn well you're gonna be that patient because they can't breathe on their own, so you're gonna have to do it for them. And having a bag valve mask for someone who cannot breathe, who's for someone who just drowned or had a tracheostomy or had a thyroid surgery, anyone who has that kind of risk, that's always a good answer to have that shit by the bedside. Okay, so what are our ventilator settings? This is something that we kind of breezed over in MedSurg 3, but here it is very simplified. Thank God, Mark Clement, because I do not have the goddamn energy to spend any more time on ventilators. So what's the context? The rate is how fast the air is going. The volume, also referred to as the tidal volume, is how much air is going in. So I can say that the air is going 3 miles per hour. Please do not put 3 miles per hour inside of your patient. Your patient will explode. That's just an example. I could say I'm going to put air at 3 miles an hour. And how much air I'm going to put in? I'm going to put in 3 liters. Now, I have no idea what are the physiological consequences of the numbers I just stated. That's just an example. So what happens? If we're putting too much goddamn air too fast, our patient's going to become overventilated. And what did we previously state in the other video about ventilation? If there's too much, it's going to be alkalotic. So the settings need to be turned down. Pretty easy. Too much, turn it down. If the settings are too low, you're going to see that your patient is underventilating. They're retaining that carbon dioxide. They're becoming acidotic. You need to turn the settings up. Questions. I hate these goddamn questions, y'all. I hate ventilators. The physician wants to wean the patient off in the morning. At 6 a.m., they're calling my ass, and the ABGs come in with a pH of 3.0, CO2 at 40, and bicarbonate HCO3 at 24. What do you do next? This indicates respiratory acidosis. What is respiratory acidosis? Underventilation. Why? Because that patient is retaining that CO2. What does retention of CO2 mean? That they are underventilated. What do we do if it's under? We turn that shit back up. But actually, most of the time, the nurse is not responsible for touching the machine. The nurse is just responsible for relaying that information to the physician or respiratory therapist. And I am so thankful because I don't like ventilators. So the response to this question would be notify the physician that the patient is not in fact ready to be weaned because I will not be losing my license for some dumbass physician. If they were in respiratory alkalosis, which is overventilated, it would be okay to wean the patient off. The patient is clearly showing that they are breathing okay, relatively in consideration to their situation, and they can be taken off. And I think that is it for. Wait. That might not be it. I might be lying. I am lying. No, I'm not lying. That's it. Woo! We're done with ventilators.